My name is Becky Worth and I'm a trustee at Soft UK. It's a privilege to be able to introduce Dr. Martin McCaffrey, or Dr. Marty as those who know him call him. Dr. Marty is a clinical professor in neonatal perinatal medicine at the University of North Carolina Hospital in the US. He is an expert in the optimal medical care for babies born with trisomy 13 and 18. I was fortunate to be able to have several phone conversations with Dr. Marty when I was pregnant with my daughter Heidi, who had trisomy 18. He was exceptionally generous with his time, and the advice that Dr. Marty gave me was the single thing which transformed my pregnancy experience. He gave me confidence to express my wishes for my daughter's treatment to my doctors, and I'm deeply indebted to him. I know that many other parents, both in the US and the UK, have benefited from Dr. Marty's wise counsel as they make difficult decisions about their baby's care. We are all looking forward to hearing what he has to say about how children with trisomy 13 and 18 are compatible with love.
Good afternoon, everybody. This is Dr. Marty McCaffrey speaking to you from Raleigh, North Carolina. I'm a neonatologist at the University of North Carolina in Chapel Hill, and I'm very grateful for the invitation to speak to you all on this very celebrated day, the 30th anniversary of Soft UK. So I applaud you all on the tremendous work that you've done and hope that this will be an interesting conversation for you all as you proceed with your very important and critical missions. I'm going to talk to you today about trisomy 13 and 18 in particular. And what I would like to describe is my journey on this road. And in that journey, the review that I have done over time and currently looking at trisomy survivals and surgery data for trisomy infants, trisomy 13 and 18, talk about medical perceptions and attitudes, talk about the tyranny of the self-fulfilling prophecy, and then get into what do parents actually think about children with trisomy 13 and 18. I want to address the topic of parents as advocates, and I would like to speak with you all about how we as physicians can partner better with mothers, with families, with parents in the care that we deliver to families experiencing or expecting the birth of a child with trisomy 13 or 18. My journey in all this is pretty typical, I think. It started out with a lot of literature like this, describing what a child or an infant with trisomy 13 or trisomy 18 might look like. Lots of descriptive terms for all the potential quote-unquote abnormalities. And pictures like this. These are the pictures that filled pediatric textbooks and that we were spoken to about. And these are the pictures that we would actually, certainly early in my career, show families when we were talking about what you might expect in terms of the delivery of a child with one of these conditions. The data was somewhat bleak and reported survivals in a sampling here of trisomy 13 and 18 at anywhere from 5 to maybe 10% or so for babies being able to survive over the first year of life. I met Saskia at a talk back then that I was invited to give in Leeds in the UK, and it was an amazing experience. And indeed, this has been the experience I've had on a number of occasions in meeting children and their families with trisomy 13 and 18 conditions. My journey, my epiphany on this journey started probably back quite a while ago, probably with the birth of my daughter, who you see here is with me at a conference that we did in Washington, D.C. It was a press conference that was discussing the impact of Obamacare that was being proposed at that time, the potential impact that it would have on families and children with special needs. And we went there to speak, and at this meeting, we met a number of families who included this woman here, Barb Farlow, who had children with trisomy 13 and 18. All of the children could not make the meeting. Some of them did. And I was actually blown away to see that there were so many stories of children with these conditions that were surviving. And this is not what I had been taught. It's not what I had been raised with. And it is not what I knew as a pediatrician and a young neonatologist. I had heard very different stories and was told repeatedly that these were lethal disorders. I went home after that meeting and started looking at the literature. And what I was surprised to find is that you actually can see, even back in the 90s, that survivals in some studies, not all studies for sure, but in some studies for trisomy 18 and 13 at 1 year showed numbers as high as 40%. And I will grant that these are a little bit selective because it was done in a network where families had decided that they would perform and have performed interventions for their children to support their care. But it didn't seem to me that this was ever going to be possible, and how could this be? So it brought me to really trying to deal with the data that was out there as far as trisomy survival data. And there's a number of problems with the data that we had then and that we still currently have today. So at the time, we have center-based studies, but the problem with center-based studies are small, and there's a relatively rare incidence of trisomies. There are large registry studies, but they are generally unable to comment on the amount of actual care delivered to babies on an individual basis. You've got studies that compare care that is delivered and the ultimate outcomes. And oftentimes these are described as aggressive care or full care versus non-aggressive care or comfort care. But there's variability in definitions. And depending on the studies, some may include feedings by tube as aggressive. Some may include standard regular newborn care as aggressive. There are infants that are diagnosed postnatally that may be characterized as receiving aggressive care, but then after a diagnosis is made postnatally, the care is withdrawn, yet they still are characterized as being cared for aggressively, and then they have a demise, which ultimately follows care being withdrawn, and that clearly can skew the statistical data. There's the issue of mosaics, which are a relatively small portion of the trisomy population, but they may skew outcomes. And then in an age with less prenatal diagnosis, back in the 50s, 60s, 70s, there may have been some cases that were missed that had died, and there may have been infants who were supported who today might not be, but there was less technology available back then. And then in the prenatal diagnosis era, there may be increased terminations for infants who might be more severely affected, but there may be more terminations based solely on prenatal diagnosis of infants who possibly could survive. And then there, of course, is provider bias impacting the course of and whether interventions are offered. So this is some data looking at pregnancy outcomes for trisomy 13 and 18 over a pretty long haul, 1974 to 2015. And this is a multi-registry population-based analysis that looks across Europe. And what you can see happens over time here is that there is an increasing number of babies who are being diagnosed prenatally, and there is subsequently an early termination of pregnancy rate that is much higher as well over the course of time for both trisomy 13 and for trisomy 18 babies on the left and on the right. So what really can we make of the data that we have in terms of what could survival be? It's quite a hodgepodge and a mishmash of data that makes interpretation difficult. But still, we have people that will talk about these disorders as being lethal or incompatible with life. But are they really? So this is data out of Canada that was published in the Journal of the American Medical Association, one of the world's premier medical journals, back in 2016. And interestingly, this data looked at babies over several periods during the course of the first year of life and looked at survival. So what we see on the left-hand side is, for instance, if you're starting in the upper box with trisomy 13, at birth, Babies who will survive through the first week of life, trisomy 13, 53%. So we lose a significant number of babies in that first week of life, 47% actually. For trisomy 18, 50% will survive the first week of life, and we lose 50%. And so on throughout the course till you get to the end of the first year of life. And it appears in this Canadian registry study, which is quite large, that of trisomy 13 babies, there's a 20% survival at 1 year of age, and for trisomy 18 babies, a 13% survival. What I would like to draw your attention to, though, is what happens if you look at babies who are alive at 1 month, the left-hand column, and then walk over to who is alive at 1 year. And for trisomy 13 babies, if you're alive at 1 month, 47% are alive at 1 year. If you are a trisomy 18 baby alive at 1 month, 36% are alive at 1 year. And there's a relatively high survival rate out through the next 5 and then the 5 years after that to 10 years of life. And I think these are numbers that no one is being offered in terms of when they are expecting a child with a trisomy 13 or an 18 condition in terms of survival, because everyone is being told that the chances that your baby is going to make it to a year from birth are anywhere from 5 to 10%. But even these numbers belie that, as trisomy 13s in this situation, 20% are alive at a year, and for trisomy 18, 13% are alive at 1 year. So one of the challenges for babies with these conditions is a high predisposition to congenital heart disease. And there is not an enormous amount of data that shows how well babies with these conditions can do with heart disease, but there has been some emerging over the last couple of years. And the numbers are small because we have not been operating very regularly on babies with trisomy 13 and 18. But if you look at this data published in the Annals of Thoracic Surgery back in 2017, what you can see is that with fully corrective surgeries, the survival times for babies with trisomy 13 and trisomy 18 after a fully corrective surgery is 14.8 years for trisomy 13 and 16 years for trisomy 18. When you look at the survivals for infants that have palliative surgeries, you can see that palliative surgery survivals are somewhat less in terms of years than fully corrective surgeries, which leads one to believe that while some babies are going to die and may not survive, there can be a significant number of babies that would survive for longer periods if we were willing to consider them as heart surgery candidates. Based on this article and some other publications around the same time, this is the recommendations that were published in an editorial in the American Academy of Pediatrics. And it's worth sort of reading through this. So as far as congenital heart surgery for trisomy babies, in the past, the decisions about congenital heart surgery were made difficult by the absence of data. We have a little bit of data now. First, cardiac care is critical importance in these babies. 91% of trisomy 18, 86% of trisomy 13 infants have some form of congenital heart disease, and it's a spectrum of severity. Only 7% of infants have actually undergone congenital heart surgery based on the data that we had at the time of this publication in this editorial. So we are treating these infants with a very different care trajectory than infants who do not have trisomy. And that will not come as a surprise to a lot of people in the audience. We do have evidence that congenital heart surgery can be considered, but we also need to fully inform parents of the significant mortality risk with cardiac surgery and the fact that there will be severe neurocognitive delays for full trisomy children that will not be corrected by correction of their congenital heart defect. And so they conclude the revolution in congenital heart surgery, even in infants over the past decades, changes the equation for infants with trisomy 18 and 13, just as it did for trisomy 21 in the past. Since that publication, we have some more recent data that was published in 2019 in the Journal of the American Heart Association. And this is analysis of the Society of Thoracic Surgeons Congenital Heart Database. And what you see here is a compilation of outcomes for babies with trisomy conditions based on their stat category. And the stat category refers to the degree of difficulty for a different surgical repair. And they range from category 1, which is an ASD or a VSD or a co-arc repair, very, very common pediatric congenital heart surgeries, all the way up to a category 5, which is the very difficult Norwood procedure and other hybrid procedures which may be undertaken for babies who have, for instance, a hypoplastic left heart. And what you can see are the survivals for these babies based on their stat category. And I'll turn your direction to where I have the red circle here, which is over on the right-hand side where we include both trisomy 13 and trisomy 18 babies and look at the in-hospital mortality and then compare it with the mortality for babies without those conditions. And for a stat 1 repair, which would include VSDs and ASDs, with a VSD being actually one of the more common defects, especially for trisomy 18 babies, we see that overall the mortality for this repair is 0.5% for all children without trisomy conditions. What you see for the mortality for babies with trisomy 13 or 18 is quite a bit higher. It's actually 16 times higher. And what you see is a percentage there of 8% mortality. So if you're looking at this, you think, wow, the mortality for my baby with a VSD is so much higher than the mortality for a baby with a non-trisomy VSD repair. It's just a very difficult thing to consider. Now, certainly there are more risks, but the mortality is picked up here in the STS database as 8%. That means if 100 babies went in to have a VSD repair done, that 92 are going to survive over the first 30 days after that surgery. And you can see similarly that mortality clearly is higher for babies with trisomy 13 or 18, but it is not necessarily a death sentence to send a child to the operating room to repair a congenital heart defect if they have trisomy 13 or 18. Certainly difficult conversations to have, and they need to be wide-ranging and consider lots of potential things, including developmental outcomes, but certainly not a death sentence based on the data, at least, that we have. So let's look at some other medical conditions and the data we have for them. And this is American Cancer Society data. It's a nice graph. It's a little bit older, but I have kept it because it has some nice pictorial value, I think. And if you look at 5-year survivals for different types of cancer, urinary, gallbladder, pancreas cancer, some kidney and renal cancers, liver, and all of these have very high mortality rates in the single digits. Yet these people with these conditions and with their families, we never describe these individuals as incompatible with life or having a fatal disease. We offer them reality, we offer them the real risks, and we talk about the likelihood that may be there for death, but we also try and offer some glimmer of hope for those who would attempt to proceed with care and with treatments. So I think this sums up pretty well where we're at. And this is from Annie Janvier, who's an incredible Canadian neonatologist and ethics expert. And she has published extensively on the topic of infants with difficult, life-limiting conditions, including trisomy 13, 18, and other things like extreme prematurity. And in this article where she talks about building trust and improving communication with parents of children with trisomy conditions, what she says is this disease is always incompatible with life. Always, I know. I am not interested in these articles. They give families hope when there is none. These are direct quotes that Annie has taken from families who've had conversations with their healthcare providers, attempting to get them to engage with them and offer some opportunity for life for their children with trisomy. And these are some of the challenges that they meet. So it cannot be understated that in spite of the fact that we can do medical supportive therapies and do medical surgical therapies that may sustain life for children with trisomy 13 and 18, they also will have severe developmental delays, and we cannot at this point certainly fix those as things currently stand. And this is great work that has been done by Deb Bruns, who's going to be speaking to you as well, on the developmental outcomes of children with trisomy 13 and 18. And what you see is a scattering of outcomes, but clearly these are children who have severe motor and cognitive delays. And this does not mean that they will never be able to communicate. It does not mean they will never be able to ambulate. It does mean that life will be extremely challenging for them, and life will be very, very different. And they will have severe developmental issues related to major categories of developmental outcome. And parents need to be fully advised of that, understand that, before we go down the road of introducing lots of medical therapies and surgical therapies. But in spite of this, parents should have the opportunity to have this information transparent and make their own personal choices. Now, the challenge comes in from a lot of angles. And one of the big challenges that families and parents will face and their children will face is the attitudes of us, the medical providers. And so I'm going to talk about the obstetrician attitudes towards trisomy 18 in particular. And this is an article that was published by Dominic Wilkinson. It's a little bit older, 2014, but it looks at opinions of those caring for mothers in Australia, New Zealand, and the UK as it relates to trisomy 18. And what you see up here is that if you ask the obstetricians in this very large survey group of 962 obstetricians, is trisomy 18 lethal? 84.5% of the docs, the obstetricians, agree. If you ask, is it incompatible with life? 54% say it's incompatible with life, which to me is always kind of been very puzzling. So it's lethal 84.5% of the time, but it's only incompatible with life 54% of the time. How do we put that together? And I think this is how we put it together. Is trisomy 18 compatible with the child having a meaningful life? And only 8% of obstetricians moderately or strongly agree with that statement. So ultimately what we are left with is it is not the care that is futile. It is the judgment of those taking the survey that the life is futile. And thus we get the characterization of lethal. Now, it's easy for me as a neonatologist to pick on obstetricians, but what about the neonatologists? So let's do the same survey with neonatologists, and indeed that has been done. And this was published in the American Journal of Medical Genetics. Same questions, basically. I don't think you're going to be shocked at the answers. So is trisomy 18 a lethal condition? 83% of neonatologists said yes. Is trisomy 18 incompatible with life? Only 45% said yes. So again, there is that divergence between lethality and incompatible with life. How do we explain that? Is trisomy 18 compatible with a child having a meaningful life? Here's the explanation. Only 15.7% of neonatologists in this survey felt that a child with trisomy 18 could have a life that was meaningful. Once again, the clear assessment of neonatologists is not that the care is necessarily futile, but that the life is futile. So the docs are a bit of a challenge here for families and parents who might wish to try and support their pregnancy or their child with one of these conditions. Let's go to the nurses. The nurses have to be better. I mean, the nurses and maybe even medical students and trainees, residents, they're not jaded. Let's go talk to them. So here's a survey that's looking at different types of nursing providers and the percent that would choose termination for different fetal anomalies. So what you have are DR delivery room nurses, you have NICU, community NICU, maternity nurses, you have children's hospital NICU nurses, pediatric residents, trainees, and obstetrician trainees, not staff people. So let's see what we see for trisomy 18. Would you terminate the pregnancy if you had a child with trisomy 18? And of the nurses, 71, 74, and 83% say they would terminate the pregnancy. Of the peds and the OBs, residents, trainees, 74 and 75% would terminate the pregnancy. This is pretty challenging. So across the board, you are dealing generally with nurses and physicians and trainees that really have a sense that they don't think that a child with trisomy 18 is a life that is going to be meaningful, at least for them and their family. I'll add, as the father of a daughter with Down syndrome, that this is pretty horrific to me. For trisomy 21 Down syndrome, much less complicated, much longer expected life for individuals with trisomy 21. Current expected life average is sitting at around 45 to 50 years at this point for individuals with Down syndrome. But on the nursing side, 58 to 61% would terminate that pregnancy with a child like that. And 43% of pediatric trainees and 73% of obstetricians would terminate that pregnancy. So I would suggest that as healthcare providers, we personally have a pretty dim view of individuals and their ability to have a meaningful life who possess these conditions, certainly, especially trisomy 18 and trisomy 13. So if we're feeling this way, how does that translate into how we talk to families and talk to parents? And this has been looked at. I mentioned Barb Farlow earlier, and I mentioned Annie Janvier earlier. Barb, unbelievable family advocate for families with trisomy 13 and 18. Annie, amazing neonatologist up in Canada, who is very much an advocate for families and for supporting their wishes and their determinations in the care of their children. So this publication, how many families have heard your baby will likely die before or at the time of birth? 94%. Your baby will not live for more than a few months if they don't die before or at the time of birth. 88%. Your baby's condition is lethal or incompatible with life. 93%. Your child will be a vegetable. 55%. Your baby will destroy your family or marriage. 28% of families were told this in this survey. And then last, if your baby survives, his or her life will be meaningless, 55%, or a life of suffering, 68% were told this by their providers. So how does this actual prejudice language play out prenatally? What does it sound like? And here are some quotes from families that I've collected over time, my last 15 years or so, trying to support and advocate for families dealing with difficult prenatal diagnoses. I found out that my daughter had full trisomy 18 when I was 18 weeks pregnant. The OB asked me 3 times to terminate, told me none of these babies survived to birth. And if they did, it was only for a few hours. I was even asked, why would you want to give birth to a baby that's going to be no use to society? When we got the diagnosis, I was asked if I minded waiting until tomorrow for the termination. An OB asked me if I wanted to burden my other kids with such a sibling. Another OBGYN told me these children have no will to live, that they are without a soul and unable to experience being alive. This is horrible, gut-wrenching thing that families have been exposed to. The trauma that we expose families to prenatally, in many cases, dealing with such a prenatal diagnosis, is just absolutely monstrous. How about postnatally, after the baby's born? So, I was told by a neonatologist no one with trisomy 18 had ever survived. I was told if somehow he did survive, he would ruin my life. I was told he would have no quality of life. We can't tell you anything positive because that would give you hope. A GYN asked me if I had any children, and I told him I had a daughter, 9 months old at the time, with full trisomy 18. Oh, he said with a sad face. So you're just like counting down the days, huh? And then this from a physician on rounds within earshot of the mother of the child they were rounding on. There's a dark cloud coming for her. So survival for trisomy 13 and 18 patients really hinges on a number of things, and what those might be has been well examined by our previously referenced friend Annie Janvier, Barb Farlow, and Annie's husband, an amazing neonatologist and clinical researcher, Keith Barrington, in this publication back in 2016. So what Annie and Barb and Keith looked at was the elements of palliative care. And what they found in this survey was that palliative care included at prenatal diagnosis, the baby got warmth, skin-to-skin care, medication for comfort, and bereavement. If the baby was postnatally diagnosed, and this occurred at a median of 6 days of age, then palliative care included oxygen, ventilation, tube feeding, and IV fluids, because the baby had not been diagnosed at that point. Comfort care for all the babies who were prenatally diagnosed in this survey was recommended. So there were no recommendations initially made for any actual medical care or stabilization or evaluation of babies. It was all recommendations for comfort care. And the biggest, strongest independent factor that predicted that a baby would not leave the hospital was prenatal diagnosis. So 64% of babies with a prenatal diagnosis died on day 1, and only 47% were discharged home. With postnatal diagnosis, only 1% died on day 1, and 87% were discharged home. And the conclusion of the authors is that it seems palliative care for children with a prenatal diagnosis is aimed at the goal of having as short a survival as possible after delivery. So let's talk to parents and see what parents think about their children with trisomy 13 and 18. And this again is a separate publication from Annie Janvier and Barb and Ben Wilfont. So this looks at full trisomy 13 or 18 children. 40% lived greater than a year. 21% lived at least 5 years. 89% of the families surveyed reported overall experience of their child's life was positive. If a child lived longer than 3 months, 50% did state, they were clear, that their child did experience more pain than other children. 50% recognized that caring for a special needs child was more difficult than they expected, and could have been prepared for. But 98% reported their child enriched their life. 82% felt that this child had a positive effect on their siblings. And then I think the money question is right here. When parents are asked if they would continue the pregnancy in the future if they discovered they were expecting another child with trisomy 13 or 18, 8% said no, 9% said they were unsure, and 83% said absolutely they would continue the pregnancy, or they never would have done prenatal testing in the first place to determine if there was any kind of chromosomal issue. So I think one of the things that we have to confront as providers, and which we force you as family members to deal with, is the meaning of words. Words like fatal, lethal, and phrases like incompatible with life. And I think this is a fantastic quote from John Lantos in a larger article that's referenced here, but quote unquote from John. And John Lantos is one of the premier pediatric ethicists in the world right now. Many clinicians object to life-sustaining treatment of infants with trisomy 13 and 18. And these views are based on two ideas. First, the trisomies are uniformly fatal or lethal. Second, the burdens of treatment outweigh the benefits. These views are no longer tenable. Repeat, these views are no longer tenable. Repeat, for clinicians who might be in the audience, these views are no longer tenable. Many infants with these trisomies survive for years. Many parents report the infants with trisomies have an acceptable quality of life and are valued family members. And at this point, an accurate generic description for the trisomy 13 and 18 conditions should be life-limiting conditions. The other thing that we as providers have to come to grips with is the journey that families are on when there is a pregnancy with a child with a life-limiting condition, or when a diagnosis is made after birth of a child with a life-limiting condition. We have the ability to make this an unbelievably traumatic experience for families. This child is been accepted as a loved member of a family. All the hopes and dreams of this family are now with this pregnancy or with this child. And now we have a diagnosis that will dissolve that future that has been imagined for that child. It shatters the world of the family, what they were expecting for that baby. What does not go away is parental love for a child. So asking families to abandon the loving parental commitment that they have made to a baby, born or unborn, in the form of discussing, for instance, abortion at the time a diagnosis is made, is absolutely heartless and cruel. What we are doing at that time is shattering a family's world. We have totally turned the family's experience on its head. Basically, they're experiencing over the next several days the death of a child that they expected, and now they have a very different child. These families now have multiple losses that they're grieving, and they are still dealing with the fact that their baby is there and their baby is a person. They are separated from other individuals. They don't know how to speak to others about this very often. It is unclear what any of this means for the future. And the healthcare systems, no matter where you are not especially adept generally at dealing with families going through a crisis like this. For me, in thinking about how to deal with families dealing with this type of an issue, I think there's an interesting acronym that comes up called SPIKE, which is a good way to structure conversations with families around this type of a situation. So SPIKE, S, setting. in breaking this kind of news to families, setting aside unlimited time with no interruptions to speak with a family, to introduce yourself, to congratulate the family on their baby, but also to be prepared to talk to them about findings that may evolve. P, perceptions, as you have ongoing conversations with these families who are dealing with these challenging issues. Ask each parent to review where they are at the current point of their evolution. Listen, be willing to listen. That is critically important. And then identify major concerns. And in an initial conversation, hopefully you can avoid these things if we try and do this as best we can. But oftentimes what has happened is families are dealing with isolation, with crushed hope, with the denial of treatments that might be indicated for other pregnancies where there wasn't a child with a potentially life-limiting condition, inability to trust providers, and then there is always the issue of parents blaming themselves for the child's condition. I, the invitation. As you're speaking with families, determine what the grounds are for sharing information and try and get a sense of how families want to come to the point to make decisions. Shared decision making is what we commonly talk about now. It's all the rage. But the fact is, and Annie Janvier talks about this, some parents want to make decisions themselves. Some parents want healthcare providers to make decisions. So the notion of shared decision making maybe should be shifted a little bit more to personalized decision making. K, knowledge. Word choice should be at a non-medical professional level. For families that are continuing a pregnancy that is a child with a life-limiting disorder, I would suggest that talking to them, if they're interested in pursuing care, about touring NICUs and seeing what they look like is important. Being honest, however, with families about what the potential for life is for their child, the child with a big VSD and a trisomy condition versus the child with a hypoplastic left heart and a trisomy condition are very different babies. And if you've seen one baby with a trisomy 13 or 18 condition, you've seen one baby. So honesty and transparency are critical. As you're talking with families, you need to be willing to tolerate silence. And this is very hard for me. I like to have the space filled with words. Silence to me can often feel uncomfortable. But as you're breaking and discussing difficult, challenging news, silence is important. And it means you need to make time for the silence. So back to the setting and making the time to have this conversation with families and not have them feel as if you are rushed for time or have them feel that they are not the most important thing in the world to you at that point, which they better darn well should be. And I think as providers, it is never our job to totally extinguish hope. There is always some hope. We need to leave the door open to that and be realistic and not unrealistic. But we should never feel our job is to crush hope because in a paternalistic way, we are doing the best thing for the family. And then E in spike, emotions. Allow space to express these emotions. Allow for righteousness related to families in these situations where they've experienced some very difficult traumatic things. And allow the emotions to clear as best you can before moving on to another topic. The last thing I would say in summary, so I kind of make this spikes, I guess, with the last S, is define some steps that can be determined to give families some element of control, as much control as they really want or need. I think it's important for parents to remind staff that even if you are pursuing active care or interventions for your baby, that you understand that there's potential for stillbirth and death for your child, that you know these things are possible. but you ask providers to continue to pursue and explore what possibilities there might be for life for your child. And I think for all of us, we should discuss all potential care options. And perhaps that would mean comfort care or palliative care. Perhaps it might mean a trial of intensive care. And it may not be black and white. So we have to develop some willingness and ability to tolerate ambiguity. So to the support groups, there's a number of them out there. I mentioned that. The support organization for Trisomy, SOFT UK, you all are an outstanding and amazing support group. SOFT in the US is a great support group. The International Trisomy Alliance is a great support group and has great materials, as does SOFT, on their websites to help families through these difficult times. They also offer information that may be bilingual, as well as information for siblings, which can be very helpful. And again, here are a number of the Facebook support groups that are listed here. And this is just a sampling. There are others out there as well. I would say that beyond support groups on the web, there are more in-depth and approaching case care management groups that are available to help families trying to deal with difficult prenatal diagnoses. And these may be not uncommonly in local Christian and Catholic ministries worldwide. And you need to know locally what's going on in your communities to identify these organizations. I would make a plug for a group that I work with called Be Not Afraid. And we're available and visible on the net at the link here, benotafraid.net. What we offer is comprehensive case management to parents carrying the term, following a prenatal diagnosis, and then support thereafter. And that support may include parents who choose comfort care. It may include parents who choose to try and stabilize, evaluate, and obtain ongoing medical care for their children. We follow families out for a year after birth. We prepare families for the possibility of a life and a death. We support families with the development of birth plans, which we feel are good guides to providers who are dealing with the families and make clear the ground that parents want to share with providers. And then we even have the opportunity, the ability to support costs for funerals and funeral planning and memory making for some of our cases. So I would start to head towards close here with just some lessons that I've learned from children and families living with the trisomy types of conditions, 13 and 18 specifically. So there is a high risk of fetal loss. That cannot be underlined enough. I mean, that has to be made clear to moms as they're going through a pregnancy. But these are life-limiting disorders, and I would plead with providers out there to eliminate quote-unquote lethal, fatal, incompatible with life language. We need to be telling families that for the full-blown trisomy condition, severe motor and cognitive disability is a constant. But what I've also learned is one person's good quality of life is another person's poor quality of life, and I don't have the ability to make that judgment for a family. Disability, point blank, does not equal death. It just does not. And life limitations are defined by the baby's unique medical conditions, not their chromosome number. So every baby should be looked at as an individual. Biases that we have as healthcare providers in terms of the personal decisions we can make absolutely can create lethal self-fulfilling prophecies. And they carry over into how we counsel families. The literature is clear on that. We need to work on that with great determination. Do everything, quote unquote, or do nothing, quote unquote. Language ignores the multiple shades of gray that exist in partnering with families dealing with babies with trisomy issues or other life-limiting conditions. And please, any maternal providers out there, do not ask a mother if she wishes to schedule an abortion on the day a life-limiting condition is diagnosed. And then for culture to truly change, ultimately what you need is a commitment on care providers to partner with individual families. And very important in all this process is for each family developing a birth plan with the family that includes a number of elements, that includes emphasizing the value of the pregnancy itself, decisions being made regarding antenatal testing, high risk testing, interventions for distress, C-section, use of antenatal steroids, discussion of palliative and comfort care versus the possibility of stabilization and assessing in the delivery room versus the consideration of further interventions after birth. Considering feeding plans, and it is something that has happened not infrequently in a number of places that while we talk to families about comfort care, the babies survive through a comfort care period and are ready to go home. And families are not prepared for that. There's been no preparation for how to feed a baby. So all those things should be considered, despite the fact that we may see medical conditions in a baby with a trisomy condition that looks severe and may be very, very life limiting in terms of minutes or hours or days. It's not always the case. So it is incumbent, I think, on us to consider all the possibilities and to plan for the possibility that a baby might survive and get to the point of going home. And then how would we arrange for care after that child does get discharged from the hospital? What kind of supportive care or palliative care or hospice care teams are available to support these families? So I think Mark Twain said it really the best. The two most important days in your life are the day you were born and the day that you find out why.